So for our next talk, we're going to do something new this year. So we'll have 2 debate style talks. There'll be a panel discussion, and then later in the evening, we'll do a more standard debate. Our moderator is going to be Becky.
While Olivier holds up the slides that I just sent him 30 seconds ago. So I'm Rebecca Millman. I am an imaging physicist at CU Anschutz, and our speakers today are Brad Lofton from Camp and Mike Silosky from also CU Anschutz. We're going to be talking today about regulations and diagnostic imaging. So we're going to go down by a factor of about 1,000 or more in terms of doses that we're talking about. So we're talking about milligray doses, not all of the crazy high doses that you all typically work with. And if there are comments from the audience as we go along, go ahead. This is, we want this to be kind of interactive. We have some questions that I'm going to pose to the speakers and just really kind of have it conversation based. It's not a point counterpoint or a debate really, because they actually align on stances on these issues. So we didn't want to make one of them make stuff up that they don't actually do. So I know that this is mostly where the diagnostic folks are on the minority here, and most of you are therapy physicists. So hopefully I think a lot of this is still going to be relevant though. So here are names. This is a diagram a picture that I put together. This is kind of, I don't know, how I view these conversations going. And I won't tell you how long I spent putting this together because it was longer than I probably should have. So the objectives are to discuss the justification and challenges in regulating the practice of medical physics and to facilitate an open discussion on this topic. So Mike, I can go through these slides as you go through those first.
Yeah, sure. Let me stand up for a second.
Can I make a comment first? So it's bad enough that we have to follow Dr. Binion with a discussion for 45 minutes on regs, but we didn't even come with dad jokes, so we're dads. So I'm sorry about that, everybody.
I'll come up with some along the way.
Thank you.
Sure, I'll stand up. Okay. So I know they asked during the first talk, but again, how many diagnostic physicists here? Come closer. You need to ask questions, not right now, but at some point, because the intent is for it to be a discussion and not just Brad and I up here talking at your faces. So before I did get started with those questions that Rebecca is going to pose to us, I wanted to provide just a little bit of framework, which I think will facilitate this sort of discussion. Obviously, the question at the top, which is the title, is intentionally clickbaity. I think that we can revise this a bit and ask, is the practice of medical physics, and specifically diagnostic medical physics, over, under, or misregulated? And that misregulated piece, I think, is the most important to point out, because this is not simply a matter of magnitude. It's not, should we have more or should we have less, but how should we go about it, right? It's a difference in kind, not just magnitude. The next piece I wanted to point out is that while we have these discussions, and I'm going to go through a couple definitions briefly, we can talk strictly about regulation. But in our field, we have multiple interventions that are not strictly regulation. So in this case, regulation is a hard and fast rule made by some governing body that we have to follow. It can be prescriptive or proscriptive. We can have, you must do this, or you cannot do this, or they can be generally vague. But there are other forms of intervention, and in medicine, as well as other fields, they play off each other. Another form of what I'm going to throw into the bucket of interventions is licensure, right? The idea being that, okay, instead of a hard and fast rule about what you're going to do, we're going to decide who's allowed to decide what to be done. Everybody, or nearly every physicist in this room, is registered with the state of Colorado, and I will assert that our registrations function similarly to the concept of licensure. They're different in some sense because we, don't have a governing body like a state medical board that's looking at it, but we all have to demonstrate some type of competency, provide some documentation, and get approval to provide certain tests. So in many sense, it's a flavor of licensure. Okay. And then I'm also going to include accreditation or certification here. Ultimately, the idea being, yeah, I've got a third-party independent organization that's going to evaluate, quality or safety performance of a procedure or a practice or a product or something like that. Again, in our field, all three of these interplay, and they can't really be separated easily. So when we talk about how should we as a field go about regulating or intervening in something, all of these are potential tools. And there's more, but these are the main ones I thought. Okay. So we know that we have those type of interventions. Question is how do we justify it? The most common one, not just in medicine, but in any type of intervention, any type of, for lack of a better term, market, is safety, right? We all know, hey, we have some rules for patient safety, we have some rules for staff safety. Everybody's familiar with, say, exposure limits to the general public, right? Somebody who's not receiving the service and isn't providing the service, but could still be impacted, things like that. And we're very familiar with that. You also hear arguments for the quality of products and services. And a big part of what we're going to discuss is how effective are these interventions at actually ensuring anything related to quality. And then a few that we're not going to spend a lot of time talking about, but is important to point out is that we also have rules and mechanisms in place to protect things like patient rights and stuff like that, which as important as they are, often it may be secondary to some of the things we're going to talk about. And the last item I'm going to have on here, and I have a question mark next to it, is the idea that is often brought up, whether it be in a political arena or anything like that. Well, if we intervene in a certain way, we can somehow save costs. I would make the argument that generally speaking, additional interventions increase costs and don't decrease them. However, for the rest of this conversation, it's important to recognize we're not talking about starting with a blank slate. We already have an existing set of interventions that we live with on a day-to-day basis, whether they be state regs or accreditation requirements and things like that. And a revising or reforming of existing regulations, if you make the proper changes, could potentially actually cost less, depending on what you're doing. Okay, so back to our initial question, is the practice of medical physics over or under misregulated? I think it'd be better to look at it in terms of the following questions. One, what are our current interventions? And what were the justifications that were provided for them? Why are we doing what we're currently doing? How effective have they actually been at achieving these ends? Obviously, we've heard arguments for safety and quality and things like that, but are we achieving those ends as well as we might effectively? What have those things been cost? And this is the hardest question to answer because generally costs are very diffuse when it comes to regulations or accreditation, things like that. It's shared across a large group of people and organizations, and therefore it's hard to put a big number on that. But you still need to consider, and what are the alternatives to what we do today? And are there better ways of going about what we do, either because they cost less or because they're, and maybe most importantly, better at achieving what we claim we're trying to achieve with these interventions. So that's the end of my blurb. That's kind of the approach to how we like to talk about these questions. And now we kind of want to go and have a discussion with all of you about this topic.
So I'm going to pose some questions to Mike and Brad, and this is really just going to scratch the surface. As Mike kind of pointed out, this is a very multifaceted topic, and so there's no way that we can get through to sort of a comprehensive review of this. But the first question I'm going to pose, Brad, what role does a QMP have in safety and quality in radiology?
So I'm going to use an analogy that Jerry White and Greg Gibbs, who's here, used to use regarding radiation oncology. And that is the medical physics office is like the nervous system of the department, right? We control the communication between implementation of technology to clinical care, right? Patient outcomes. We're that bridge. Jerry also used to say that the most expensive piece of equipment in any hospital that you go to is the linear accelerator, which I think is probably still true. And it just so happens that you physicists, most of you in here, are the only person in the department that really knows how that works, right? On some level, I think that applies to radiology as well. The scale is different. The severity score is different, right? We're talking in terms of milligray as opposed to what you guys do with gray all the time in therapy. But I think the principle still applies. our responsibility is to translate technological implementation to patient care in hopes of improving outcomes, clinical outcomes.
So Mike, do you have anything you want to add?
Yeah, I would add that if you look at, I forget what exactly it is, it's a AEPM statement on what is the role of the medical physicist. It specifically points out, hey, you're there for safety and quality. The idea being that those are central to our purpose for existing within in the medical space. And so, I would bring it back to the previous question. Knowing that we are there for safety, so that means, in the radiology space, there is radiation safety, there is also MR safety, things like that. In fact, I'd argue that MR safety is the most important safety thing that any of us are going to deal with it on the imaging side. But we're also there to ensure quality, and that quality comes with a set of quotation marks around it, because quality of what? I would make the argument that ultimately it's quality of the medical service as a whole. Radiology is a part, but it's not simply how well did this machine do its job. That is part of it, of course. We want all of our instruments to be functioning properly. We want all the people who are using our instruments to be using them correctly and effectively. We want the people who are interpreting the images generated by those instruments and those people to do that job well. But in the end, it's getting a quality service to that patient. And our role, sometimes we forget that, especially in diagnostic. It's different in rad-onc. It is a little different in nuclear medicine as well, but often there's a bit of a separation there. And we think to ourselves, quality is making sure that this device does this thing. When that's true, but only part of it.
So APM MPBG 10.B is the APM scope of practice, just since you referenced it.
Oh.
So I think that you bring up an interesting point in terms of quality and radiology. And when we're talking about safety and quality, of course, a lot of those things are intertwined a lot of the time. But what are the primary risks in radiology? That's a little bit more apparent in radiation therapy. We're talking about delivering very large amounts of radiation to places where you don't want it, or not delivering enough radiation to places where you do want it. And I think the risks are a lot more obvious. So taking that down to radiology, what are the primary risks?
Yeah, I think the irony here is we spent the last 20 years talking about low dose CT and how low can we go and really driving down that dose. I don't remember a lot of conversations about what that does to diagnostic power, right? And so I think the irony is I feel like the biggest risk in radiology is missed things. What are we missing, right? The severity score in radiology is a little bit different than oncology because for the most part, you guys know what you're treating, right? You see it in the image. You do treatment planning. And diagnostic, right? Not in surgical image-guided surgery and so forth, but in diagnostic, true diagnostic imaging, we don't know what we're looking for, right? That's why image quality is so paramount. And so I think that we need, when we talk about risk in radiology, it's most important to start with what are we not seeing? What are we potentially missing, right?
And I think that's it's a critically important point, and it's one that I think often gets overlooked, not necessarily because people don't think it's important, but it's really, really hard to measure. It's really hard to do a study that says, okay, how many of these images was the quality not good enough so we couldn't make an accurate diagnosis. And you don't know that because you don't have the information to really make that. It would be a very complicated sort of thing. Mike, do you have any?
I have actually two comments on that. The first is an example of recently implementing a particular protocol. Again, this was in nuclear medicine, but I was in the middle, as I often am, of a debate between physicians and technologists, the staff, saying, how short can we image for, right? And of course, the argument the staff manager said is, how short can we go for it still to be okay? That approach is fundamentally flawed, though, because the reality of the situation is, for any particular one of these patients, I'm going to have a range of of tumors of different levels of detectability. Some of them are larger, some of them are smaller. Some of them have uptake that is not that far above the background. Some of them have ones that are very clear. As you are reducing your image quality, you're playing a game of probabilities. It's not a threshold of good or not good. It's, oh, your likelihood of missing something increases. I can't tell them, hey, below this bad, above this good. But that is what is wanted. And so there's an educational factor here. It doesn't change the fact that there's diametrically opposed values going on, obviously throughput versus image quality, but that's part of it.
Yeah, and I think that that's an important distinction is for any imaging facility, there is a real push by administrators to get as many patients imaged as possible. And I know that at University Hospital up in Aurora, we have wait times of several weeks for some exams, and this is running scanners a long time. So it's partly financial, but it is partly one of the things that patients complain about most. They don't complain and say, I don't think my image quality was good enough. They complain because they couldn't get an appointment quickly enough. So there are competing pressures here in terms of sort of the reality and what some of these risks are.
So I've got a question. When we're talking about the regulation and how regulators should come up with if we're overregulated or underregulated, like when does it cross over into over? Is it, outcomes per dollar, physicist hours per finding, patient harm averted? Like where do we, like, what is the threshold?
So
You're speaking to where we need to go, right?
Yeah,
It
or
needs
just,
to be
yeah.
tied to outcomes. I think that what we would say, I don't know, Mike, you speak to this, is traditionally that has not been the case. We have a lot of very prescriptive regs. We'll talk about this hopefully a little bit later, but they're not necessarily tied to failure mode. We do it because we do it. We use the cadence for an annual test because that's just what we do. There's a historical inertia associated with that I don't think is directly applies to clinical outcomes.
I think, sorry, go ahead, Mike.
No, go ahead.
I think the other thing that's worth pointing out is, Brad talked about clinical outcomes and things like that, and having the physicist duties and regulations tied to patient outcomes. I apologize if this displays my ignorance. It's been a long time since I've done therapy, but the range of applications in imaging is very, very different. The practice environments are different because you may have a CT scanner in an emergency department versus something that's being used for surgical treatment planning or surgical guidance versus something that's being used for, we work in every department in the hospital. And so that outcome can vary a lot.
Okay, go. Please.
Just a general question in regards to, like an actual risk, a while, I don't know, 10 years ago or so, about the New York Times article saying that somebody lost their hair and stuff. I haven't been able to find what are some actual numbers, because sometimes, doing radiosurgery, we have to, maybe rescan somebody, quality wasn't as good, we're reconstructing. So can you give I know I want to say CTI is like 75 just on average for whatever.
I hope not.
That's
But, yeah.
75 milligrams.
Yeah, that's the upper ACR upper limit for a head, right?
So when you're looking at these numbers, because sometimes we're tweaking the numbers, what would you recommend as, hey, because at the end, maybe the DOP is like 5,000. Sometimes a little alert is popping up based on the business. But can you talk on that in regards to risk?
I want to make a couple comments because the question that you posed with that case where they had the radiation-induced alopecia, that is a great example of, I'm sure that CT was fine. I'm sure it had been checked annually by a physicist. I don't know that, but I'm guessing, right? That's an opportunity for education, right? That was a misuse of something. That was a misuse of a clinical device. Something that we as physicists need to be speaking more into, right? Clinical ongoing education. So
that technologist did 200 scans of that patient.
yes.
I mean, so it was, yes, there were hundreds
misuse.
of scans that were being done. So that was very much a, let's say a learning opportunity.
So I don't want to ignore your question because I think that's something to discuss. I'd actually rather leave a CT physicist to answer it than somebody like myself who's primarily nukes. What I would say that is reinforce what Brad said, was no amount of what we do today could have fixed that problem. Because the machine was probably fine. Somebody came in, did their annual, so it looks good, you know what I mean? There's that sort of thing. Our current approach to the problem as, and I think Brad's gonna talk about, maybe we'll touch on this a little bit more, quality managers, which is much of what the role of the physicist really is or ought to be, has this as a complete blind spot.
I will comment though on the, if it's okay,
No, please, please.
on the CT dose issue. There isn't an exact number because the reality is we don't know. The risk is small enough that we haven't been able to quantify it. It takes very huge amounts of, epidemiological and patient data. We're talking millions and millions of people to be able to characterize that because the risk is either very small or non-existent. I think that one thing to keep in mind though is, and this is always kind of my plug, just speaking on behalf of myself, is risk and benefit, right? There may be a very small theoretical risk from having another CT scan done. But if the benefit is that you have more accurate treatment planning, I think that is clearly a large enough benefit to offset any potential hypothetical risk that there may be from the CT. Because what you're doing, having any sort of inaccuracies in that treatment plan or not being able to fully visualize is the same thing with, even with surgical treatment planning. There are risks to surgery, and so having accurate imaging information to help guide that surgery has been proven to improve patient outcomes and surgical outcomes. And so yes, it's not a life and death thing as it often is in radiation therapy, but we're talking about massive, it is a huge quality of life issue sometimes too. So it doesn't have to be, the risk or the benefit doesn't have to be, okay, otherwise you're likely going to die. There are a lot of other things that can provide very real benefits that might justify that risk.
Asan Sameh has shown this a lot recently in papers that clinical risk almost always outweighs radiation risk in radiology, right? The two things were mentioned earlier that I just want to reiterate because they are important and I think they get buried along with the educational piece. MRI safety is a massive concern right now. And that's an ongoing source of physicist intervention that's really not codified in a regulatory sense. And then skin reactions from, FGI procedures,
Fluoro-guided interventional.
Yeah, sorry. So I just wanted to reiterate that those are two kind of very present risks in radiology that I think justify.
I did have one more risk. Oh, go ahead.
So I like the fact that you brought up, Rebecca, the benefit to risk, because I like to think of this more as a benefit to risk ratio. And the problem is, of course, the quotient is measured in different units,
Yep.
right? So how to equate them is very difficult. But the first thing you suggested, Brad, was that the risk was missing something. To me, is a lack of benefit.
Yes.
Rather than a risk, right? The benefit is reduced. And the risk is similarly reduced because I reduced the radiation to make this image, a CT image, but my ability to detect small cancers has reduced as well.
Yep.
Right. And the question becomes, is that a disadvantage in terms of the benefit to risk ratio?
That's a good clarification. Yeah.
And I'll just follow that. The one thing that people with gray hair in this room will remember is when we were going to school, like in elementary school and stuff, if someone got sick, they went and had exploratory surgery, right? We did not have CT scanners when I grew up. They didn't exist. And there was a concrete risk that your friend never came back from the hospital, right? They would die because of the anesthesia, right? And remember, this is anesthesia in the 60s, not anesthesia in the 2020s. We don't have that today, right? We don't do exploratory surgery. We do a CT scan. And yes, there is a theoretical risk that in 30 years you will get cancer, but that's 30 pretty good years.
And even then it's theoretical. I would just lean heavily into that.
Hold on, there's one back.
I would say another risk is ignorance. So if the radiologist is like, oh no, we can't do the CT, and send the baby to go do MRI, we've seen where that's very detrimental as well. Or, techs aren't educated in how to properly use the system, as she mentioned. There's just different levels of education, and information that we need to have in radiology, and it's a pretty big risk to not know
Absolutely.
what you're doing or what the risks are or the benefits of an exam, and to say, hey, don't ever use CT, only do ultrasounds or MRIs. That's not the right answer.
Well, and those conversations are what a physicist needs to be having with staff and with
Yes.
patients that we're not, right? But that's a point of emphasis within AAPM right now.
That actually feeds right into what I was going to mention. But no, it's perfect actually, because in terms of the current practice framework, current regulatory framework, how many times has a new technology, that whether it be a piece of software, a piece of hardware, a new tool on an existing machine, been introduced into the clinic? You, as the physicist, don't know about it. The physicians don't understand how it works. Either it is misused or not used. You know, we purchase something and we never use it because nobody knows how to make it work. You know what I mean? Everybody has had this happen. Why? Because I'm too busy doing an annual on another portable. And there's no structure in place for the proper flow of information, for the expectations from the clinical staff that, hey, the physicist is going to work with us to do an implementation. That problem is a real problem, and our current model doesn't do much to help us hit that blind spot. Sorry, you had a question. I didn't mean to.
Yeah, I think I'd rather move on with what you're talking about now, though.
Oh, please.
I'm curious because now we're starting to dip a little bit into like regulation and the impact of regulation on diagnostic. You've touched on something that I feel like I think radiation oncology is a bit opposite of diagnostic in this sense, and that you guys don't really have the time to be the technology implementer in the same way that a radiation oncology physicist does, because you're often doing all these other things. So I guess my follow-up question to that would be, do you feel like this is a regulation problem or a staffing problem?
I think it is a combination of things, but I think that the current regulatory framework sort of impacts the culture in a certain way, that there's an expectation of what the physicists do, right? I mean, when you staff, well, I think Brad
So
can talk about this more. But
can you elaborate on that? Like, what is, when you say that the regulatory framework sort of influences or dictates what the medical physicist is doing, can you explain what that is, what that looks like? I know you can.
I was just about to.
I
was trying to do that before you stepped in. So say I'm in a staff or rad onc department with physicists. What dictates that? How many physicists you need to have on board? Obviously, there's their instruments, but a lot of it's what kind of cases, how many patients, things like that, right? Patient volumes, right? In a radiology department or an imaging setting, we don't staff based on that. We staff based on how many instruments are there alone, and therefore how many tests are you going to have to do to meet the requirements. So that's one example of it, right? Now, the practice in diagnostic does vary a lot between, it's not just an academic versus consulting either. Different groups, whether they are either, vary significantly in their practice and who does what. So there are plenty of people who are either diagnostic or nuclear medicine physicists that are doing something more similar, where I'm an instrument implementation expert who builds protocols, develops new techniques, things like that, educates them. But there's also a lot of it, and for some reason the regulatory aspect of it that doesn't do that. So you could argue, well, if we had infinitely more staff, then we could do things differently. But I think our next couple of questions are getting to the point is, but are we receiving a benefit from all of that work?
So then are you arguing that it's more of a case of misregulation as opposed to overregulation? Because it feels like, okay, let's get rid of all of the really specific rules for how physicists test CT scanners, for example. Would we then need to implement new regulations that state there just has to be a QMP in the department for this case load, this imaging load? Or would you say kind of carte blanche, no regulations
I'm
Or
hoping,
like just total like loss of
So-
regulation.
I'm hoping we will get to that.
I think we are gonna get to that in our
So-
questions, but I don't wanna blow.
So there's a question or comment in the corner over there. He's been waiting very patiently for a while.
Brad, kind of going by one of the things you said, like one of the biggest risks is us missing something.
Mhm.
But quite often, at the clinic at radiation oncology, we have like a diagnostic MR and we're like, oh, that's not good. It's
Yeah,
thinner slice thicknesses and all that.
yeah.
So as diagnostic physicists, like where does that, like I would think that thinner slices would give you like more detectability and all that stuff. Who is having that discussion? Like, how do you determine, like, do they come to you? Like,
It varies
Yes and
greatly.
amen. It does vary, but what I would say is the current system rewards kind of minimum compliance, even if you're an accredited facility, right? Because we're not taking into account in a proactive way what the specific site needs are. If you're a radiation oncology department, you have certain needs for your MRI image quality, right? Spatial resolution, things like that, that may be more enhanced than even the ACR requirements. We've actually had this issue come up at Penrose before years ago, right? It passed ACR accreditation scans, but we were having issues fusing the images, right? And there was some geometric distortion that we found past one standard, but not the clinical use case, right? So what I am advocating for, what we are advocating for, is we have to have a flexible regulatory framework to enable us to account for that, to use methods and processes more than prescriptive procedures, because we're missing stuff.
Did you have a?
Yeah, I'm done.
I'm done.
I am very interested in the differences between federal regulation in the diagnostic field and state regulation. So I'm on the APM state champions thing, and it's really interesting from your guys' perspective. Is it better to have these bigger federal regulations or this like patchwork of like state experimentation with regulations? I know there's vast differences between Wyoming and Colorado and New Mexico, all up and down the line.
I
And
mean, I think there are advantages and disadvantages to having local control of something versus, federal control of something. Yes, it would be nice, and especially because now, there's people who are, I have a company that's centered in Colorado, but I serve like 10 different states, right? And so obviously that's a challenge for meeting the different rules in the different places. And so there are some practical advantages to having something centralized. But I think that what we're really what I'm advocating for was, again, both a more flexible framework that approaches the problem utilizing all the interventions that we mentioned and not just hard and fast regulation at all. But I think it's necessary to couple that with a cultural change within our own profession. Diagnostic physicists seeing themselves as something different, and eventually the rest of the radiology community saying, oh, this is my diagnostic physicist. He's here to help me do this. Not like when I took over the job I have today, like, oh, the guy who used to do this did it at nights. We never saw him. And I had my department chair that I started with here say, oh, well, when things are working right, you never see the physicist. I'm like, that's the complete opposite approach to what we're advocating for as an integrated team member. And so I don't have all the solutions for the answer to your question, but something that facilitates that change and sees you as, oh, you're a team member that helps us accomplish these missions, not you're the guy who looks at stuff when I'm not here.
Can I make a comment?
Oh, yeah,
Sorry.
of course.
So I think that to in response to your question, because I know we have to wrap it up in the next like 5 or 6 minutes.
Good.
So federal versus state regulations on the diagnostic side of things, most states' regulations are very similar to what the CRCPD suggested state regs are. In the state of Colorado, there's a state statute that says that the state X-ray regulations have to match the CRCPD suggested state regs. Any exception to that, they have to actually go and make an argument in front of the medical board to get approval for that. The other thing that's worth mentioning is, and I know this was going to come up later, but we're not going to get to it. It takes a very long time for a regulation to change. I'm going to be talking about gonadal shielding and other types of patient shielding in a little bit. And there are still things in state regs that mention radiosensitivity factors for gonadal shielding that were updated in the early 90s, but were not updated in the state regs. And so I think that part of what they're advocating for is instead of having regulations that say, this is exactly what you need to do, because that does not have a very long shelf life.
No.
Technology changes, all of these things change, is instead of being very prescriptive, being able to say, these are the sorts of, this is the person who's qualified to decide what tests need to be done. And kind of going from there, because one thing that I've been told many, many times from somebody I greatly respect and I'm very good friends with at CRCPD is she'll say, Rebecca, not every state has certification for medical physicists. So we have to design regulations around states where anybody can essentially act as a diagnostic physicist. So there's that too.
So there's someone in the back and then we can.
Can I just comment on Rebecca's, just very quickly? So
You're president of APM, so yes, or
Yeah,
it's
so,
been alive, so you can do whatever you want.
CRCPD Part F, which is what we're talking about right now, is currently under review and XCOM has the review package right now. We have to get comments back next Tuesday, I think. So there will be a revision to CRCPD Part F this year.
So you had a question right there and then we'll get the one in the back.
It's more of a comment. So thinking of changing the culture, if we could change CMS and get reimbursement for diagnostic, I think that would aid in helping us to feel like, hey, we are supposed to be here. We're a clinical partner. We're valued in a different way. Then right now, we're just a cost to the system.
That's the thing. There's a model for this that's
Yeah.
working, and all these, most of
Exactly.
these people here do that,
Yeah.
right? And so we have a picture.
In fact, it actually feeds into something that I think we were gonna bring up, but maybe we'll. But I would point out that, as I did at the beginning, in Colorado, at least, we have something that's almost like licensure. And where we have to demonstrate a competency, be approved to provide certain services and fulfill a certain role. We should be leaning on that. If anything, I would argue for something more similar. I can't believe I'm arguing for it, to licensure. Where the physicist demonstrated the ability to make these decisions and can decide for their facility and for their needs what is appropriate. Now, we can argue to what extent. A good example is, say you're starting a new facility and you need a radioactive materials license. The way that Colorado handles it now is you submit a plan. It doesn't tell you, the state doesn't tell you what to do. In terms of all your instruments and everything like that, you submit a plan and say, we're going to do this, we're going to do this QA, this is going to be responsible, this person is going to be responsible for this. It gets approved, and then I conduct it. So they're not prescribing to me what I need to do on all my instruments. I'm telling them, here's what I'm going to do on these things, and they're holding me to my word. So they still have a hand on the tiller. But they don't, it's not that type of prescriptive control. And something more like that, to me, seems like a better future for diagnostic physicists. And we already have models for this. There's a million licensed professions nowadays, but medical licensure is a perfect example. And one that we are intimately tied to. Now, whether we're not going to have a state board of medical physics, I'm not saying we're necessarily going to have that. But something along those lines where they see us differently, we see ourselves differently, and we're doing, not that we're not doing some of the things we're already doing, but we're approaching the profession differently.
We're the only ABMS recognized specialty that is non-physician, right?
Yeah.
So I think that means something.
One of two.
It should mean something.
Geneticists.
Geneticists, okay. Yeah. No, what Mike said is absolutely correct with this thought of you provide the program that you want to conduct and you provide all the control points and how you're going to manage it. That actually drives us to being more data driven, right? We can prove that we don't need to do this annually because I have all this other great data, but I'm actually using better techniques to show when intervention is needed by the physicist. And all this stuff is published. It's out there. We're just not adapting it.
So we're at time. We're gonna do this one last question in the back and then we're gonna have to wrap up. Unfortunately.
So I love everything that you're saying. And I just wanted to draw this into the therapy folks that are here also, that I actually see a lot of parallels between this discussion and what we do in therapy. Maybe not in the context of state regulations, but in the context of accreditation. We do a lot of prescriptive, regular periodic QA that is probably unnecessary. in lieu of like what I would call smarter QA, data-driven QA. Just because, you know, we risk not being accredited or getting dinged on our accreditation because we're not doing this test on monthly, or we're not doing like these tests on annual. And so like, I guess what my question is in order to get to this point, like what can we do as physicists? Like, how do we do this?
I don't know.
So one thing, and I'm sorry because I talked briefly about this last year, but one thing that therapy has going is TG 100. There's a really great example, and there's a statement in, I don't know if we have that written down, but it basically says, this allows the methodology for you determining what's important to do in your radiation oncology department. What we're arguing, so you guys kind of have a framework, and what I think is good about ACR accreditation in oncology is they're more willing to look at your data and adapt and say, okay, well, you've proven that you don't need to do X, Y, or Z because of these stats. We in imaging haven't even gone there, right? And so this is really what needs to happen. Thank you for showing this.
I promised Brad that I would include this last quote.
So I love this comment, and I'm going to read it. There is nothing so useless as doing efficiently that which should not be done at all, right? And everybody in here, therapy and diagnostic both, know of the things. We know of the things that we do, and we're like, why are we doing this? This never fails, right? We don't account for occurrence. We don't account for severity to the patient. So we have to, this is like what we're really arguing for. Mike said this earlier, but it's a change of mindset, really among all of medical physics, but especially in diagnostic imaging. So we didn't even get to.
So Mike, do you have any parting words?
Well, you know what? I'll walk back to my last joke and say, what you can do is start talking about it. If you're a part of a training program, start talking to them about it. That's the first step, right? Just try to see things differently. What is eventually will be part of it is dealing with the existing regulatory framework, but I don't think that's the first go. And immediately go into them and say, hey, guess what, state of Colorado, you got to do it different. It's probably not the way. Start to discuss this. I think the other thing is propose, you know, we've talked at a very high level today, but building functional examples of data-driven QC and implementing them and then publishing it and showing it and saying, listen, I used to do this every test once a quarter because that's what we always do. It's a waste of time. Here's why. There's a better way to look at this if I do this, and doing it and executing it. And building that piece by piece is something that anyone can contribute to.
Yep.
And yes, it will be difficult at first to get our accrediting bodies or our regulatory bodies to accept that as a replacement for what they already have. But if we don't do those things, then we're never going to get there.
Can I make one comment about trainees? This will be the last thing I say.
Yeah.
If you have an imaging residency, I would encourage us, Renee's not here.
Say that's not it, Grace.
Get your physicist in the clinic. Get them seeing exams, get them talking to radiologists. If we are not meeting with technologists regularly, if we're not educating them, if we're not meeting with RADs regularly, we're not clinical. We're machine testers. That's what we do. But I know of some residencies that 90% of the residency is EPEs. And that's not good. That's not good for patient care. This is kind of, it's ingraining this system that we're a part of that needs to change.
So Mike and Brad will be here all day. Talk to them. That's great. I do want to say partially, because this is being recorded, we are very fortunate in Colorado that we have very good relationships. I think most of us with the state regulators, and the state regulators are always very interested in learning more about what we do. And this, of course, is not like, hey, let's just go ahead and make this big, huge change. But I do want to recognize that in Colorado, we are fortunate to have that structure. So I know we're over time. I'm sorry, Andrew, because we're eating into your time. But thank you, everybody. I think the discussion was good. I know this is a fraction of what we're going to cover, but I think the discussion was worth it. Thank you.
Thank you. Take a 5-10 minute break, talk to the vendors.